to the telephone, distinguished guests, colleagues and friends. I was just asking if there's a solo. Short. Yeah, it's a pleasure to be here today amongst experts and friends to present my name. My husband would be very happy, or he would be smiling that I'm taking Marumatakimanu. He's my working name is Dr. Farah. So Marumatakimanu is my husband. And he would be smiling if he heard me. But anyway, I'm here with Dr. Quinita Mangra. She's the newbie in Rheumatic Heart, and she's doing our echo clinics back home. So thank you. So on behalf of the team, I'm going to present on rheumatic heart disease and scabies. I must admit, when I saw this in the invitation, I'm thinking, why is scabies been attached to rheumatic heart disease? And after hearing all the presentation this morning, I'm actually convinced that there must be some connection there. Okay, so I was given the outline of the presentation, so I just wanted to show you that we do have policies. We do have a health sector plan where rheumatic heart comes in. It's one of the strategic outcomes in our health sector plan. And that is the strategic priority number 7. So our key outcome is in number 5, where they say 95% of children in primary schools are to be screened for rheumatic heart disease. And I was looking through and they said primary schools for year 1 and 2. But we know that rheumatic heart disease is in the older children from our previous surveys and research. So, before that, we also do have a child health policy book for adolescents, children and adolescents. And in all these strategic health sector plan and policies, there's no mention of scabies in it. And so, as you rightly said, there's no, it's a neglected disease. So these are the services we provide. I'm going to stand here, it's easier. The services and activities we provide in Samoa. So in the past, we used to have everybody come to the main hospital to do our prophylaxis. So over time, we knew that was too many, because we also included the adults. So we decentralized. We had all the district hospital do their IMI injections, and we also transferred all the adult patients to the medical department so they can continue the secondary prophylaxis. We do rheumatic heart disease clinics in the peripheral hospital. We've started with Savai'i, and unfortunately we haven't rolled out the services to our other district hospitals. So we have about 10 or maybe 11 district hospitals in the whole of Samoa, Upolu and Savai'i. We also do clinics 3 times a day, a week, and that's usually done by Dr. Quinita at the main hospital. We have New Zealand cardiology specialists that come biannually. We have Dr. Nigel and Dr. Claire. Some of you might know, and Dr. Tom might know that. So they've been really great. We appreciate the assistance coming to. We echo, we screen, echo, and we find the patients that need to be seen by them, whether they need to go for surgery overseas. So that's their part in coming over to see us biannually. So all the ones that they think they need surgery, we refer to New Zealand, and apparently we send quite a few to New Zealand for surgery, mainly repair rather than valvular replacement, and of course our congenital. So we had the Rheumatic Prevention and Control Program. It was funded by overseas, I can't remember, maybe on 2 occasions, and apparently that has collapsed. I'm not sure why, but we're trying to revive that program at this moment with the help of New Zealand, our New Zealand colleagues with Cure Kids at the moment. We have a BYU screening. We have the American team that used to come in. I think they started in 2009 up to 2019. They came in to help us a lot with our screening of a lot of schools. And so we were able to pick up a lot of kids who have rheumatic, mild or even severe. A couple of years ago, we developed guidelines to the district hospitals, so all that has gone to the district hospitals to look at sore throat and those with established lesions. And then, of course, we have the school health visits by our district nurses. They apparently have just found out about it. They do it, some district does it twice a year and some once a year. So they actually do a whole examination. If they see infantile scabies and even listen to the heart, they refer them over to our main hospital. So these were the screening back in the days when I was very young with the New Zealand team. And you can see that the small portable echo machine there, it's like a phone. So the Americans come in with a fantastic technology. And so we weren't able to get them off there. So we're trying. We wish we could. So look at all the things that they do during the screening. We go for 2 weeks, and there's a bunch, like maybe 20 or so, or maybe 40, I think. They do health education. The nurses are taught how to listen to murmurs, and then they go through the screening process for those who have the murmurs. So it's really helpful, and they can develop videos and ads for TV. So that's why a lot of our kids know they have the songs for rheumatic hearts, and so they know a lot of our people already know what rheumatic heart disease is all about. So let me just go through some of this data I was able to receive from the team because I wasn't working for a while. And this is what they gave me. So a total number of children screened over the last 2013 to 2018, because I wasn't able to get the other data. They screened about 30,361 children from the ages 5 to 18. They were able to screen 2 to 4 schools a day. And about 400 to 500 students per day, and the mean age was about 9.8 years. And they found that it was, out of all 57 females, there was always more females than males, and they did about 1,100 comprehensive echoes. So when they hear them murmur, when they see a lesion, then they refer to a whole comprehensive echo. So these are the findings from the screening. So 55% had congenital heart disease. So this is why it's good to have screening. You can pick up those with some congenitals. And 20 of them had the cardiac surgery. There were 147 incomplete data. So out of that, 878, 24 had definite rheumatic heart disease, and 143 had definite advanced, and the others were mild. So that's our prevalence, 16 per 1,000 from the screening alone. We weren't able to get any other data besides this. And from our register, we keep a register at our main hospital, but also the district hospitals have their own register. And this is 179 from 2016 to 23. As you can see, there's only 61 at our main hospital, CT Mall, and only 51 are active. And you can see that this more than half are non-compliant with the injections at the moment. So these data, I was able to get our students to dig up the data. So you can see in per year, so I don't know that there could be a duplication in these numbers, but I was shocked to see that we don't see many rheumatic heart disease per year, but I found out that there's 20 over the years 2021 is 27, so the average is about 26 patients registered per year, and 2023 is only 9. So the common age group at diagnosis is usually the 8 to 7 years. So according to the strategic plan, and what we see, it's better that because we have a population of about, I think, close to 85,000 in those less than 18, I think. We can't screen all the schools because there's so many children, but we will focus on these age groups that are 8 to 10 and upwards. So you can see this over the years, it's still the same thing, more on the 80 and upward, the years, 8-year-olds and above. So that's the map of Bolu, that's where we are. We have a big island, we have a few cases, but mostly it's concentrated around the Apia urban area. So there's a lot of densely populated with people coming in from the other villages to come and stay for school in the main island. So that's the area there. So our compliance rate, sad to say that 49% are non-compliant. The other 16% is the ones that they don't have any idea where these stations are. So some of the problems we have is tracking them down because when they run out of credit, they change their numbers, and so the numbers we don't get, and so it's really difficult to follow them. And some migrate overseas and some to other district hospitals, so we're unable to track them down. So admission to our main hospital, the drop in 2019 is not a good one, but it's because we don't have the records of it. So that's the number of admissions per year. Either rheumatic heart disease, acute rheumatic fever, or it's just for investigation. So this data that we got is from the admitting diagnosis, so it's not the final diagnosis. Unfortunately, the people who record these things they take the admitting diagnosis rather than the discharge diagnosis, so they might be unreliable because we don't see this many per year of patients admitted to hospital with rheumatic fever or rheumatic heart disease. So you can see it's the same pattern. And the number of admissions by gender from 2018 there's more female than male. So referral overseas, I gather there's about close to 10 to 15 cases that we refer overseas for surgery. And the estimate costs, I think if our friend from PMA, it's roughly around 50,000 New Zealand dollars for surgery. So it's one of our goals is trying to reduce this because this unfortunate deaths and preventable deaths and the many children who have developed rheumatic heart disease go through this surgery and then will be ever debilitated with this disease. So the positive and negatives, with the positives are we are able to do, they don't have to come to the hospital, the main hospital anymore. Now they can do it anytime, any day at the district hospital, and all the nurses can give the IMI penicillin. We have registers in all hospitals. I was able to get that. I didn't want to bore you with the data from all the district hospitals of the numbers. We do the echo clinics. We are trying to train more medical officers to do echo with the help of the New Zealand team, the 2 kids that we're trying to revive this rheumatic heart disease program. They will be able to help us train more, not only the medical doctors, but sonographers in doing echoes. So screening with the help of the American team, we've done a lot in terms of screening, and we will start again next year. We've asked them to come back again. So they're coming in next year to do our screening again, and we hope the local team can continue to do screening every year. There's a lot of public health awareness programs on TV. And then we have the cardiologist visits from New Zealand. So what are our problems sustaining that rheumatic heart disease program? It was difficult on two times they've had the program going. Is helping to sustain the money to pay these people to do this. So when the money ran out, the whole program collapsed. So we're trying to revive it again. And next week we will be seeing New Zealand cure kids to come and help us get this running again. And we don't have a centralized registry of all the cases, so each district hospital and the main hospital have all separate registers. But we need to have a centralized registry so we can track and we can follow these patients up. Of course, our compliance rates, we've checked on all the district hospitals. The compliance rates are quite low, and we need to work on that. We are seeing younger patients with severe illness, and I guess over the years we've had measles and then the COVID and the lockdown. We weren't able to follow up a lot of these children, and we are seeing by younger kids with severe disease. We mentioned about difficult follow-up. We don't have mobile. We only have one echo machine in the hospital, and we can't take that to our screening, and we can't take that to Savai'i, the other island, because it's a bulky one, and we treasure this expensive machine in our hospital. We hope to get some from New Zealand if they're willing. And we need more screening, so we propose to do more screening with myself and Dr. Quinisa the other half of the year when BYU has finished their screening. And more children and younger children are requiring surgery. So those are some of the problems we have at the moment. So in terms of scabies, I don't have much information on scabies because I'm really happy to say that we don't have scabies now. Because I've asked around as well in the district hospital, because we all have doctors, medical officers at the district hospital levels. And I was able to talk to them, and they said they have not seen scabies. So that's a good thing. But we, like I said earlier, in the past we only saw young babies, some babies who had scabies rather than the older children, and it's probably because they don't bring them in. But I found this when I was researching that they did a study in 2018. It was an observational cross-sectional survey for children between 4 to 15 years attending the primary schools in one of the districts. And this was their finding. The prevalence of impetigo was one of the highest globally. It's 57%. And there were more in younger children and in the males. The prevalence of scabies, however, was 14.4%. That was in 2018, early 2018. And the transmission of Staph aureus was predicted in children of the same school. The carriage rate for strep pyogenes was less than 2%. And they mentioned that although scabies is an important risk factor for impetigo, however, in this study, and the study they did in 1999, scabies was the prevalence was far lower than that of active impetigo. It was 14.4 versus 31.6%. And secondary bacterial infection of scabies was uncommon in this study, in that study in 1999. So that was the finding. That's the only thing I could find on information on scabies. And as clinicians, we are not seeing scabies, and we hope we can go back and see how rheumatic heart disease so far after the introduction of this triple therapy MDA. So it was this study that actually was the reason why we started on the triple therapy MDA in August. So this study was done in February, and in August we did the triple therapy MDA. So I guess that would probably be the reason why we don't see scabies, and hopefully not ever. But we would like to find out what the prevalence is with rheumatic heart disease after that. But what I love, I'm sorry, school visits. So like I mentioned, they do the school visits, so it's a good thing that these nurses are doing a lot of work. We were surprised that they do this every year. So they check all they go with the dental team as well, they check the dental, they check their hearts, skin. So the nurses are doing a fantastic job at doing these visits. So that's that. So a lot of the projects that we do, we work with the Ministry of Education. So before we go out into the community, we always go through the Ministry of Education. They have some representative out in the villages that we go through to say we're going to come in to do so and so projects. So it's a good way of getting to do work out in the community. So we need to address these public health measures, and we need to address these dry wounds or skin infection like household. I don't know. This is probably the same as what we've seen in other islands. We can't really do much about one house and all the children stay in one room. And so it's one of those things that we still have to educate our people about, and just personal hygiene. All right, thank you very much. That's from Samoa.